Hello everyone and welcome to the Yorkshire Regional Webinar. My name's Hannah Parker and this is Sarah Moore, and we are both highly specialised congenital cardiac sonographers at Leeds Teaching Hospital Trust. So it fits quite well that we're actually talking about congenital heart disease today, with it being Congenital Heart Disease Awareness Week. The topic single ventricle, although single ventricle is a huge topic, our main focus of tonight is hypoplastic left heart syndrome. We've got four great speakers tonight who I will run through later and introduce separately, but we'll be covering hypoplastic left heart syndrome all the way from antenatal diagnosis up to adulthood. So to kick things off tonight, our first speaker is Jan Forster. Jan is a consultant congenital clinical scientist, and she's also head of congenital echo department at Leeds Teaching Hospital Trust. Jan is also the lead for the BSc Congenital Heart Disease Accreditation and has been a fellow at the BSc since 2020. Thank you, Jan, for presenting tonight.
Thank you, Hannah. I'll just start the presentation. Okay. So as Hannah just mentioned there, I'm going to be talking about the antenatal diagnosis of hypoplastic left heart syndrome. So this is probably something that people aren't really so familiar with. So hopefully it'll be really interesting for everyone just to understand what we do. So the things I'm going to talk about today, I'm going to talk about what hypoplastic left heart syndrome is. I'm going to go through the normal antenatal cardiac screening views, look at some abnormal views and go through a couple of cases with you, and then have a little look at the antenatal outcome data. I'm going to arrow down. That's not actually moving, is it? Can you help, Sally? Thank you. So hypoplastic left heart syndrome, we know, is the most severe form of congenital heart disease that we come across. And it accounts for about, congenital heart disease itself accounts for about 1% of all cases of congenital heart disease in the general population. And of that 1% of the background population, about 2 to 3% of these cases will be because of hypoplastic left heart syndrome. The important thing really to understand about this condition, it's a real spectrum of conditions, and there's not just one presentation or one appearance that we see when we have this condition. So essentially it's where the left side of the heart hasn't developed properly, either because of mitral and or aortic atresia, and so all of the structures on the left side of the heart are really small. Next slide. I think the mouse isn't working for me, Sally, so if you could advance it. So there are different subtypes of hypoplastic left heart syndrome. So depending on whether the mitral and the aortic valve are fully atretic or stenotic. And postnatally, these cases might present as critical aortic stenosis with poor function or severe coarctation. Oops, hang on, sorry, this is not going to be too good. It's just gone ahead when it wasn't meant to go ahead. I think there's a bit of a delay on it. Can we take the one slide back, Sally? Thank you. When we've got this condition, because we've got the left heart structures that are really small, because there isn't much blood flow through this part of the heart, then as the pregnancy develops, then the left heart of the left side of the heart doesn't develop properly, and so it doesn't grow properly. So it's a condition that evolves during the pregnancy. So we might have one appearance at 20 weeks, and by the time the baby is term, we might have a very different picture. If we don't treat this condition, we know that these babies will die in the first few weeks of life. We do now have a treatment pathway for these babies, and it's a really complex pathway. It's a staged palliative repair, something we call the Norwood procedure. And Peter will be talking through that procedure a little bit later on in the presentation, but it's a really complicated process. Next slide. If we think about the normal antenatal screening pathway, most ladies will have a scan called the dating scan between about 12 to 14 weeks in the pregnancy. And this is really just to make sure, to establish that the pregnancy is viable and to make some measurements to estimate the due date. At this point, we also measure the nuchal translucency at the back of the baby's head, which again can be raised for a couple of reasons. If there's a chromosomal abnormality, it might be raised. And also, if there's a cardiac condition, it can be raised. The 20-week scan, or the anomaly scan, occurs between about 18 weeks and 20 plus 6 days. And this is really the only opportunity that the obstetric sonographers have to assess the cardiac structures. So there's 5 views that they're expected to obtain to help them to establish normality or not. Some ladies will then go on to have a growth scan, depending if there are any fetal or maternal concerns, but the majority of our referrals will come from that 20-week anomaly scan, although we may pick up some from the dating scan and some from the growth scans, and those referrals will come into fetal cardiology. So in the Yorkshire and Humber region, Leeds is the referring centre for all of this area. So it's a really big catchment area that we're receiving our patients from. Next slide. Can you advance that, Sally? So obstetric scanning is very different to cardiac scanning. So we tend to use an obstetric machine to do fetal echocardiography. We use a curvilinear probe, and we have different challenges to the challenges that we normally see postnatally. So you can imagine the baby can be lying in any position within the mum's abdomen. So we have to try and work out the orientation of the baby to begin with, work out if the baby's head is up or down, baby's transverse. So we tend to do these very big movements, but then also some really subtle movements to evaluate the fetal heart. And I think it's worth just reminding us all that at 20 weeks, the fetal heart is the size of an acorn. So it's a really small structure, and we're trying to look at the structure within that to identify all of the different connections. Next slide. Quick recap on the fetal circulation. So in the fetus, we're going to get oxygenated blood coming from the mum's placenta up the IVC, entering into the right atrium, crossing the foramen ovale into the left side of the heart and perfusing the rest of the fetus. Deoxygenated blood is going to come down the SVC into the right atrium, mix with some of the oxygenated blood, and then pass into the right ventricle and the pulmonary artery. In the fetus, we don't need to have much blood flow down the left and right branches of the pulmonary artery, so predominantly flow is going to go in the connection that's open in the fetus from the pulmonary artery to the aorta, so the ductus arteriosus. Next slide. The obstetric sonographers are required to take these 5 views, and essentially what they're doing is working up through the baby. So the first view is called the situs view, and then they're serially going up towards the baby's head and obtaining these different views. Next slide. So these are some images here of the sort of views that we'd expect to see in the fetus. So the first view is what we call the situs view. And once we've identified the position of the baby, which is left and which is right, we're then going to look at the abdominal vessels. And we can see that the descending aorta is slightly to the left of the spine and the IVC is anterior and to the right. And this then infers to us, just go back again, sorry. This then infers to us that the position of the heart, position of those organs is correct, and that the atrial situs is normal. The 4-chamber view is the second view that we take, and here we're looking to see that the balance between the left and the right side of the heart at 20 weeks is normal. So we can see 2 atria, we can see 2 ventricles, we can see the ventricular septum, the atrial septum, and the the mitral and the tricuspid valves opening normally. If you just can go back one slide, Sally, and then come back into this slide, they'll play again, which might be a bit easier for people to appreciate what we're looking at. Thank you. The third image along is now what we call the left ventricular outflow tract view. So again, this is sort of equivalent a little bit to a parasternal long axis view, where we can see the aorta coming off the left ventricle, and we can make sure that the ventricular septum is intact. We're then going to come up a little bit more towards the baby's head, and we can see the pulmonary valve coming out of the right ventricle, giving rise to the main pulmonary artery. And then the final view is what we call the three vessel view. So this is the view that we're not used to looking at postnatally. And here we can see the pulmonary artery on the left-hand side, giving then next to it, we can see the transverse aorta and the SVC in cross-section. And we can make sure that the relationship of these arteries is as we would expect it to be, and that the size of those and the relationship of them is indicating in this picture that we've got a normal left-sided arch. Next slide. So we're going to have a look at some pictures now in a baby with hypoplastic left heart syndrome. So here's the situs view. So we can see that the left is at the bottom of the screen in this position, and we can see that the abdominal aorta is present to the left of the spine, but with hindsight it's probably a little bit small. So some of the things that we're looking at are really subtle findings to actually to make note of. Next slide. So here's our four-chamber view. And we can see here that the left side of the heart and the right side of the heart aren't equal. And sometimes when we're doing fetal echo, it's difficult to know whether it's the left side of the heart that's small or the right side of the heart that's big. And so what we do is make various measurements to establish what the normal range should be. And in this case, it's the left side of the heart that's small. So we can see the left ventricle is very small, it's very globular, and we can see some brightness to it. This is something that we call endocardial fibroelastosis, or EFE, and this is suggesting to us that this myocardium is damaged already, even at 20 weeks. Next slide. We can look at pulmonary vein flow. So we can use what we call power Doppler when we're looking at a fetus to look at these really low velocity signals as the flow's coming into the left atrium, and we get the normal pulmonary vein flow that we would see postnatally. So the pictures on the left are normal pulmonary venous flow, but if we look at those pictures on the right, we can see that we've got some evidence of restriction here. So we've got flow reversal and a very restrictive pattern, and if we saw something like this, this would be a concern to us. Next slide. Colour can be really helpful to us as well. So here we can see that the flow on the right side of the heart is, we've got normal laminar blood flow, but on the left side of the heart, we've got very little flow coming into it. And we can see a little bit of mitral regurgitation, and that's because this mitral valve hasn't formed properly. Next slide. If we then come up to our left ventricular outflow tract view, you can see here the tiny little aorta, ascending aorta arising from that globular left ventricle. So this is only about 1 millimetre in size. So these structures are really, really tiny that we're trying to look at. And we can use our Doppler techniques to try and assess the flow in the heart at this point. But one of the challenges that we have is that the angle of the Doppler might not be in line. And so actually that can be really challenging to use the Doppler as well. Next slide. If we then come up to the three vessel view, so this is the view that isn't a view that we're so familiar with as postnatal echocardiographers, but essentially we're cutting, if you look at the schematic diagram on the right-hand side, we're cutting through the duct, the aorta and the SVC, and we would normally expect blood flow in the duct and the aorta to be in the same direction, so be in the same colour in this orientation. But what we can see here is that because flow can't go through the aortic valve and into the ascending aorta, we've got retrograde flow coming from the duct, and the transverse arch is very small as well. So all of these things are really poor signs when we're looking at the fetus. Next slide. So normally when we see parents with a fetus at 20 weeks, once we've decided what the diagnosis is and established what's going on, then the options are presented to the parents. So they're counselled by the fetal cardiologist with one of our specialist nurses present, and these are the things that we discuss with them. So basically the diagnosis is explained to the parents, we talk about the surgical palliation and what can be done for the baby, and they've then obviously got some decisions to make. So they can continue with the pregnancy and go down the surgical route if that's what they want to do. They're able to choose to terminate the pregnancy if they decide they don't want to continue, or the third option that we talk about nowadays is comfort care as well. So they may decide that they want to continue with the pregnancy, but then choose not to treat the baby once the baby's born. And that's obviously a really difficult decision to make. All of these decisions are very difficult decisions to make. We would then see the parents again at about 28 weeks. You can imagine that first discussion can be a really difficult discussion. So we sort of rescan them at about 28 weeks, review the diagnosis, see if there are any changes that have occurred since the scan at 20 weeks, look for these features that would indicate to us that we've got a sort of poorer prognosis. And then we would again see them in the third trimester to talk about the place of delivery. But these babies essentially will be delivered in the surgical centre. So for the Yorkshire and Humber region, these babies will be delivered in Leeds. Next slide. So going to look at a few cases now. So this is a patient that was referred from one of our local district general hospitals with suspected hypoplastic left heart syndrome, came to us at 21 weeks, and they had 2 previous children who were alive and well. Next slide. So these are the images that we obtained. So again, we can see that the left side of the heart looks very small. The ventricle isn't contracting very well. And with the colour on the right-hand side, the top right-hand side picture, we can see flow into the right side, but not into the left. On the bottom panel, we can see we're looking at pulmonary vein flow. So here we're using a technique called power Doppler, and this is a slightly different technique to some of the Doppler techniques we use postnatally. We're using some amplitude data here as well as velocity and directional data, and that helps us to really pick out the low velocity flow coming back from the lungs. And we can see here on the spectral Doppler a little bit of flow reversal already. So this would be something that we would be concerned about. Next slide. We can use our pulse wave Doppler to look at flow in the right side of the heart, and we've got on the top left-hand picture normal biphasic flow across the tricuspid valve. You can see here as well that the pattern of that flow in a fetus always shows this restrictive pattern, so we always have a smaller E wave and a larger A wave. If we look at the left side of the heart, we've got monophasic flow across the mitral valve, so again that's a concern to us. Picture on the bottom, we can see again in this 3-vessel view retrograde flow in a very small transverse arch. So again, that's a concern to us. And the picture on the bottom right-hand side is a picture that hopefully you'll recognise from a sort of a parasternal short axis type view. We can see the aorta in the centre, which is much smaller than the pulmonary artery. Next slide. So these findings suggest to us that this baby has got both mitral and aortic atresia with no forward flow in the transverse arch, and we've got features of restriction in the pulmonary veins and monophasic flow on the inflow. So that's giving us, again, a poor prognostic pattern. This baby was born at term, had an atrial balloon septostomy immediately, and then you can see went down a complex pathway. So although we talk about these 3 operations, this child is now 5 years old and has already had 10 cardiac interventions. So when we talk about 3 procedures, this is really the best case scenario, and often it can be a much more stormy course than that. Next slide. So the case I'm going to show to you now is a case that came to us last week, and I think it highlights some of the issues really nicely. So this baby was referred to us at 20 weeks and 6 days from a local hospital. Again, it was a 3rd pregnancy. They'd had low risk early trimester screening, and mum's BMI is 30. So again, one of our difficulties sometimes is the BMI of the mum can really limit what we're looking at. The obstetric sonographers had made this statement about the referral, and we always ask them, we like them to try and sort of explain to us what they think they've seen. So these were the features that they noted on the anomaly scan. They said the aorta appears enlarged in the 3-vessel view, and that there was a 5mm echogenic focus noted within the left ventricle. They weren't sure if this was something that was normal, whether it was a calcified ligament or whether it was something else. This picture on the right-hand side is what we call an echogenic focus, and it's something that we see really commonly in the fetus, and it's something we don't worry about at all. So if we just see one little area of brightness, we know that that will just resolve during the pregnancy and it'll go away and it won't be a problem. Sometimes we see them in the myocardium, like there's 2 little foci here, or sometimes we see them related to the subvalvar mitral apparatus. So from the referral, we weren't sure exactly what we were going to be seeing here, but it was more that it suggested the aorta looked large that was the concern. Next slide. So we can see here a 4-chamber view. This baby is lying in quite an awkward position, and the baby's shoulder is right in front of the cardiac structures that we're going to see. So sometimes we've got arms and legs and all sorts of things getting in our way. And just as postnatally, when you're scanning a baby and the baby's ribs get in the way, you can imagine all these other structures can really inhibit what we're trying to see. But what we can see here on the mitral valve on the top picture is that this valve looks really abnormal. It's dysplastic, it's not opening very well. So rather than being these little echogenic foci, this is really a structural problem with this valve. And when we put the colour on, we can appreciate there's a significant amount of mitral regurgitation. So this would be a real concern. Next slide. As we now come up to our left ventricular outflow tract view, so the top picture, we can appreciate that there's some thickening of the aortic valve as well, and the ascending aorta looks bigger than it should do. So this is this post-stenotic dilatation that was what the obstetric sonographers picked up as the aorta looking enlarged. When we put the colour flow on this baby, we can see that we've got turbulent flow across that aortic valve, and we're picking up a velocity of about 3.4 meters per second. So we've got really significant aortic stenosis. Blood flow in the fetal heart at 20 weeks should be about 70 to 80 centimeters per second. So this is a really increased velocity. Next slide. If we look now at the three vessel view, again, the aortic arch looks big related to this post-stenotic dilatation. At the moment, we've got forward flow in that aortic arch. Next slide. So our findings at 20 weeks and 6 days were that we had a dysplastic mitral valve. We've still got biphasic forward flow at this point, but we've got severe mitral regurgitation and some flow reversal. The aortic valve is also very abnormal. The aortic annulus is measuring about 3 millimeters, so that's giving us a Z score of -1.3, but we felt the effective orifice area was even smaller than that. So this valve is certainly much smaller than it should be for this gestation. So we've got a picture of severe aortic stenosis with post-stenotic dilatation. Next slide. So these parents weren't really expecting such a significant abnormality. So you can imagine having to break this news to them is really challenging for the fetal cardiologist. We felt that it was likely that this valve was going to need early intervention, and we're really concerned that this baby is going to progress to hypoplastic left heart syndrome with reduced flow through the structures as the pregnancy goes on. And so this picture could change to being more of a smaller globular ventricle as time goes on. So the options have been discussed with the parents. So we've talked about single ventricle physiology and palliation. We've talked about whether they want to continue or not, and we've talked about comfort care. And because we're so concerned about this baby, we've said that we'll see them again in 2 weeks to try and help them with that decision making. So they're due to come back to us next week for us to review the images and see how things are progressing. Next slide. This is a graph that just shows how good we are at picking up hypoplastic left heart syndrome, essentially. And you can see this graph along the bottom is from 2012 to 2022, so over a 10-year period. And the very top line is the antenatal diagnosis of hypoplastic left heart syndrome. So even 10 years ago, when essentially the obstetric sonographers were just looking at a 4-chamber view, this is something we'd expect to pick up antenatally because it looks so abnormal. Nowadays, with these additional views that we now take these 5 views, then we can see that actually the antenatal detection rate is more like 95%. So it's one of these conditions we would expect to see or expect to diagnose antenatally. Next slide. Just going to talk a little bit about antenatal outcomes now. And this paper was recently published, and Peter Lilitos, who is speaking next, was the author of this paper, and it basically looked at the antenatal outcomes for various different single ventricle pathologies in a multi-centre trial. And so it's looking at babies over a 7-year period and looking at the survival for each lesion. Next slide. Picking out of that data, we're just looking at the Leeds data here. And so in that period, that 7-year period, there were 112 antenatal diagnoses of hypoplastic left heart syndrome. And of those 112, 60 of them decided to either not continue the pregnancy or to opt for comfort care. So it's a reduction of 54% straight away. So we had 52 babies that had the intention to have treatment. Sadly, 3 of those demised during the pregnancy, and 1 of them was lost to follow-up. So although that sounds a little bit careless, we do have obviously people moving in and out of region. So sometimes, we diagnose somebody and then they move and they may go overseas or to a different centre. So we had 48 live births. The first stage of the surgery, as Peter's going to be talking about later, is normally within that first week of life, but we had 4 babies that passed away before they got to that point. So these are really, really sick babies, and 44 of them survived to first procedure. So you can see that it's a really, really terrible diagnosis to make. Next slide. So again, one of Peter's papers, just looking at the Leeds data in our patients after they've been born in our high-risk clinic, where we monitor these patients really carefully, looking at a 5-year period and looking at their survival up to the Glenn procedure. So next slide. And we can see here a slightly different cohort of patients. We've got 5-year period between 2016 and 2020, and we had 86 antenatal diagnoses. 40 of those decided not to continue or to opt for comfort care. 1 lost to follow-up again. So we had 46 live births. We then added in 5 postnatal diagnoses. And again, we had 23% dying prior to the first Norwood procedure. So 40 of them went on to Norwood. 30 of those entered our high-risk monitoring programme, and 26 of them reached the Glenn procedure. So you can see these babies are really, really fragile. So it's a really stormy course for these babies and these families. Next slide. So to summarise, hypoplastic left heart syndrome is a really severe form of congenital heart disease. It's a spectrum of anomalies, and it certainly does evolve during the pregnancy. There are chromosomal and extracardiac structural associations associated with this condition as well. But we know now that we can go down a surgical palliation route and have this single ventricle physiology. And we know these patients, however, have got a really limited life expectancy, but we do have patients that are now in our adult congenital clinic. And again, you'll hear about those as we go through. So next slide. That's the end of my presentation. So I'm happy to take any questions, or we've got some panel discussion at the end as well.
Hi, Jan.
Hi.
Thank you very much for that presentation. It was really, really good. And we do just have a couple of questions, if that's all right with you.
Yeah.
So what would the sort of the earliest you may see a hypoplastic left heart in a fetus?
Okay, so the heart is fully formed by about 8 weeks. The limitation of us making the diagnosis is really the resolution of the ultrasound machine. So if you bear in mind at 20 weeks, the fetal heart's about the size of an acorn. At sort of 14 weeks, it's probably about 1 centimetre in length. So it's a really small structure, but we have started to do a lot more early scanning in the department now. And so if we get a referral from the dating scan where there's a concern that there's a real problem with the fetal heart, then we have diagnosed hypoplastic left heart syndrome at 13, 14 weeks. So that helps parents a little bit with decision making. Obviously, we have to be really confident in that diagnosis at that time, because people are making decisions on what we're seeing, what we're saying.
Super. And we've just got one more question as well, just before we move on. Someone's just interested to know if you ever use 3D echo in fetal, or is the image resolution too poor? Does it add anything?
So we do have a 3D probe on our fetal echo machine, and we have used 3D. It's quite challenging, I would say, to use 3D in a fetus because the baby's constantly moving. So the fetus has to be quite still for you to take a 3D acquisition. And then you have to crop into it and do all of the post-processing. So it is a bit time consuming. I think as echocardiographers, fetal echocardiographers, what we do is the 3D in our heads as we're going. And so we build those relationships as to our sort of the spatial relationship of different structures. So yes, you can use it, but it's challenging.
Super, thank you very much.
Thank you.
So if any more questions do come through, I'm sure we can answer them at the end, but we are going to move on. So our next two speakers are going to speak back to back, and then we will open up for questions after they have both been. So up first, we have Dr. Peter Lilitos. Peter is a consultant paediatric and fetal cardiologist. He also works for Leeds Teaching Hospital Trust. He does hold the EACVI accreditation, and he's also dual accredited in general paediatrics. So thank you, Peter, for talking tonight.
Thank you for having me, Hannah. Okay, so I'm just going to share my screen. Can you see the presentation full screen there?
Yeah, looks good, Peter.
And great. And does it change slide?
Yep.
Brilliant. Okay. Yep. I'll start then. Okay, thank you for having me. I'm Peter Lilitos. I'm a consultant paediatric cardiologist at Leeds, and I'm going to now just talk. This is a talk about principles, not about echocardiography as such, because my colleague Sarah Moore is going to go through that. So this is more about a theory about postnatal management of hypoplastic left heart syndrome, right from birth all the way through to childhood. So the objectives are as follows. I'm going to give. Oh, the screen has got. It starts again. There we go. An example. Hypoplastic left heart is an example of a single ventricle. Overview of its management after birth to being a younger person, the surgical pathways involved, principles of follow-up, survival and morbidity, and so forth. So, as Jan's already alluded to, hypoplastic left heart is dramatically different from having a normal heart. You can see the normal heart here on the left of the screen, 4 chambers, including 2 ventricles. And a hypoplastic left heart, you're missing essentially a ventricle. A single ventricle means that 1 ventricle is missing. The hypoplastic left heart means you've got a single right ventricle. So the only way for your oxygenated blood to get to your body is from your left atrium, egressing through the patent foramen ovale, reaching the right side of the heart, mixing with the systemic blue venous blood, and then making its way through the pulmonary artery. That's the exit of the heart in this condition. And then the blood's going to go one of 2 ways, to the lungs and or to the duct. So if you think about postnatally what will happen, think about this picture here. So the oxygenated blood coming through the patent foramen ovale is critical, and you need a good patent foramen ovale for blood to egress out of the left atrium. That now mixes with deoxygenated blood in the right ventricle, and the one exit is through the main pulmonary artery, and then it can go one of 2 ways, to the lungs and to the body via the duct. So critically, you need to keep that duct open to maintain systemic perfusion to the body. It's a duct-dependent systemic circulation. So prostaglandin is the medication we use intravenously to maintain ductal patency, and without it, the baby cannot survive because blood can't get to the body. And we assess closely on echo the atrial septum to see if it's patent or not. Thereafter, once you have the baby stabilized, it's an issue of balancing 2 circulations: pulmonary circulations, i.e. blood flow to the lungs, and systemic circulation, blood to the body. And you need to balance them. If you've got too much blood going to the lungs, you're not going to have enough blood going to the body. So you get poor systemic perfusion, your lactates go up, organ dysfunction. It's not good for you. And with that, you've got high oxygen saturations because too much blood is going to the lungs. So high oxygen sats are not good here. Conversely, if too much blood is going to the body, not enough blood's going to the lungs, then you're too hypoxic. So a balanced circulation generally is represented by your oxygen saturations between 75 and 85%. So the babies are blue, we tolerate that. As long as they're not too blue, that's fine. And we can manipulate these circulations as well to try and bring blood to where we want it to go and balance the circulation. So we try to manage these patients in air because supplemental oxygen is a pulmonary vasodilator and will encourage blood to flow to the lungs. If they require mechanical ventilation to manipulate the circulations, we can again manipulate pulmonary vascular resistance by driving up CO2, for example, which raises PVR. And we can also manipulate the systemic vascular resistance using systemic vasodilators such as milrinone to encourage more blood flow to the body. ultimately, once we stabilize the baby, it's consideration whether this major palliative surgical pathway is appropriate for the baby. And we say palliative because we're not correcting the circulation here. We can't create another ventricle. It's going to be a single ventricle. That's a very abnormal circulation, and the aim is to prolong survival. I will go through these 3 stages in more detail, but essentially you're converting this systemic RV, or a single RV, into a systemic RV and rediverting the systemic venous blood flow straight to the lungs in this series of operations. The Norwood operation in the neonatal period, and the Glenn operation at 3 to 6 months, and finally the completion of Fontan at 3 to 4 years. And I'll go through these now in more detail. And prior to embarking on this major surgical pathway, we need to select the correct candidates for this. All our cardiac surgical cases are discussed as in MDT. And possible reasons why we may not intervene include being low birth weight, being premature, valvular regurgitation from the offset, especially tricuspid regurgitation, which significantly increases your risk of mortality. A restrictive atrial communication. Again, we come back to this. You can surgically correct restrictive atrial communication, but it's the long-term damage that atrial restriction has caused up to this point when you're assessing, because if blood cannot egress out of the left atrium, that chronic back pressure through the pulmonary veins back to the lungs will have affected the pulmonary vascular development during the fetal stages. So if you have poor lungs, you're going to have poor physiology to have a single ventricle pathway. So the restrictive atrial communication is a prognostic factor in deciding whether to embark on this surgical pathway. Poor RV function, of course, is not good because that's the only ventricle you've got. So I'm going to mention the hybrid procedure, just because some people may hear that it's done, but sometimes this is done pre-stage 1. For those that are initially too fragile to undergo a Norwood, for example, they're just a bit premature, they're slightly low birth weight, but otherwise, if you feel if you can just get them grown a bit, they may do to embark on the surgical pathway. So this is basically a holding temporizing procedure, and it's a hybrid procedure because it combines both catheter and surgical technique. So via catheter, a stent is placed in the duct to prop it open, thereby securing the systemic circulation. And pulmonary artery bands are placed surgically to restrict excessive pulmonary blood flow, as we say, balance the circulations. And a balloon atrial septostomy is done to augment egress from the left atrium. But thereafter, whether the hybrid is required or not, the first stage operation is called the Norwood operation, and this is done in the neonatal period. Let's walk you through it. So here's a hypoplastic left heart, as we've demonstrated previously, and you're converting it to this. The right ventricle is going to be your systemic ventricle, and the only way out of the right ventricle is your pulmonary artery. But you need to make this now into an aorta, what we'll call a neo-aorta. So the operation involves creating this neo-aorta by fusing it together with the native hypoplastic ascending aorta. So the main pulmonary artery is disconnected from the branch pulmonary arteries, so the blood supply to the lungs is taken away. The main pulmonary artery is then opened and it's fused together with the native pulmonary artery, and a patch is also used to augment the caliber of that. You maintain a communication with the proximal native ascending aorta, so you can still get perfusion to the coronary arteries. I'll show you that in a minute. But then you've also got to get blood to the lungs now, because you've disconnected your pulmonary artery from the branch pulmonary arteries. So you create a systemic arterial to pulmonary artery shunt. And this is an example I've given here is a BT shunt from the innominate artery to the pulmonary artery. But there's also another technique, which is what we use in our center, called the Sarno modification, which involves connecting a prosthetic conduit from the right ventricle directly into the pulmonary artery. So now your right ventricle is pumping blood to the body, but also to the lungs via a shunt. As part of the operation as well, you're also going to do an atrial septectomy to open up the foramen ovale into a big communication, so you get unrestricted left to right flow through the PFO. So that's your Norwood. As I alluded to in the last slide, this is called a DKS, or Dame's case stance, or anastomosis. You have to get blood to your coronary arteries, which I've painted in green there. So the native aorta is fused together with the knee aorta, so you get a retrograde supply to those coronary arteries. So thereafter, this is a bit of a precarious time, and all the patients that survive this enter our high-risk program. The Norwood circulation is fragile. You've got a shunt-dependent pulmonary circulation on the background of already precarious circulation. So this interstage mortality in the literature is up to 20% between 1 and 2. And in our series, as Jen mentioned, it's about 13% for those that enter our high-risk program. Some that are too fragile to go actually stay in hospital until their Glenn procedure at 4 to 6 months. For those that go home, they're followed very closely in our high-risk clinic, about 2 weekly. This involves echo, monitoring growth, feeding, oxygen saturations, essentially markers of well-being. At home, their weights are measured. Their parents are trained in measuring the oxygen saturations. The parents are also trained in recognition of deterioration and trained in CPR. They have open access arranged to their local hospital, so they can be rapidly assessed. MRI and catheter assessment plus or minus interim procedures are often needed to plan the next stage of surgery and optimize the circulation as best can. So this is a major undertaking and a very intensive work. And that's all to get them to this stage, the Glenn operation at 3 to 6 months. So on the left of the screen is your Norwood. This is an example of BT shunt Norwood, or in our centre we'd have Bassano. But what you're going to do now is convert it to what you see on the right of the screen, a Glenn, which is essentially taking down the systemic arterial shunt and plumbing in the superior vena cava directly into the pulmonary artery, leaving the inferior vena cava still directly connected to the heart. So you're still getting mixing of blue and pink blood. Now, the timing of this operation is variable. Invariably, a prosthetic shunt from the Norwood, you're going to outgrow. Prosthetic shunts don't grow, so the baby will become progressively more blue. And it's about timing, about the right time to intervene with the oxygen saturations and weight and well-being, etc. Why not do a systemic arterial shunt? Sorry, put the systemic venous superior vena cavas directly into the pulmonary artery in the neonatal period. Why do we bother with a systemic arterial shunt? Well, it's because the pulmonary vascular resistance is too high in the neonatal period. So plumbing the superior vena cava directly into the PA in the newborn period just wouldn't work. The PVR is too high, and that takes weeks and months to settle down. So around about this time is the right time. And it's once you've had that done, this is the SVC into the PA, things are more stable. And we grow them to about 3 to 4 years to do the completion of Fontan operation. And again, the child will become progressively more blue as the amount of systemic venous return to the PAs it starts to be outgrown. So around 3 to 4 years is where you then plumb in, anastomose, the inferior vena cava directly into the pulmonary artery. So now all your systemic venous blood, all the blue blood, is bypassing the heart altogether and is passively returning to the pulmonary artery without a pumping chamber, leaving the single right ventricle being devoted to pumping blood to the body. Now, as part of the completion of Fontan, which the IVC is connected into the PA, they leave a fenestration, which is a communication between the conduit and the right atrium. And that's essentially a blow-off hole, because pulmonary vascular resistance can be a bit labile, and you want somewhere else for the blood to go if it struggles to get into the PA. And it's important to say that survival to this stage on national data is just over half, 55 to 60%. So it gives you a level of the undertaking that there is. So post-Fontan, otherwise also known as TCPC, total caval pulmonary circulation, does what it says on the tin. All the cava are now anastomosed into the pulmonary circulation. Essentially, your oxygen saturation is essentially now near normal, probably low, mid-90s, never fully 100% saturated because of the fenestration left in the conduit. And also your coronary sinus drains into the right atrium, which delivers deoxygenated blood from the myocardium. And we follow these patients generally 6 to 12 monthly, depending on how stable they are and whether there are any complications. And once they reach adult life stage, which we define as 16 years, they're referred on to our adult congenital colleagues, which Helen will talk about that stage a bit later. They get regular echoes, of course, to examine the RV function, the valve function, the Fontan circuit, the fenestration, and the arch. They receive blood tests to monitor the kidneys. They're often on medications which can affect the kidneys. The liver can be affected. I'll mention that in a minute. The patients are often anticoagulated because of that passive systemic venous return. That's more sluggish blood flow. It's prone to clotting. We don't want any clots in our Fontan circuit. Arrhythmia surveillance is undertaken because they are high risk of arrhythmias from all the suture lines and surgeries. MRIs and further catheter procedures are often done to troubleshoot and optimize problems as they're found. So in terms of long-term survival morbidity, as Jan's already alluded to, this is guarded. And survival generally, once you've got through Fontan, is into your teens and early 20s. And why is that? Well, your systemic right ventricle was never designed to be a systemic right ventricle. It was designed to pump blood to the lungs. And also, you've got a passive systemic venous return into the pulmonary circulations, which is heavily reliant on low pulmonary vascular resistance. So trying to look after those lungs, keeping the pulmonary vascular resistance low is crucial for this circulation. But invariably, this circulation is very abnormal. The systemic RV, it starts to tire, it starts to fail, no matter what you do. These patients are at risk of sudden death owing to arrhythmias. And those that do not demise that way, unfortunately, there's a slow decline in RV cardiac function, and that has a knock-on effect to the other organs, particularly the liver, the gut, and the lungs. Learning difficulties and neurodevelopmental morbidity are common, likely owing to chronic hypoxia early on in life, which affects neurodevelopment. And sadly, transplant usually is not an option for these people because of the multi-organ dysfunction and the scarcity of hearts. So in summary, hypoplastic left heart is an example of a single ventricle, in this case, a single right ventricle. Initial newborn stabilization involves maintaining the ductal patency with prostaglandin to maintain the systemic perfusion, assessing the interatrial communication, and thereafter balancing circulations. Careful selection of surgical candidates is crucial to make sure the most appropriate babies are selected to embark on this major surgical pathway. So the surgical pathway is the Norwood 1 in the neonatal period, Glenn operation 3 to 4 months, which SVC into PA, and finally the completion of Fontan at 3 to 4 years, IVC into PA. High interstage mortality risk between stage 1 and stage 2. Ongoing surveillance post-Fontan for complications, cardiac and other organs, and long-term survival is limited. Thank you. Very happy to take questions later in the proceedings, but in the meantime, I'll hand over to my colleague, Sarah.
Thank you very much, Peter. I will just introduce Sarah. So Sarah Moore is one of the highly specialised congenital cardiac sonographers at Leeds Teaching Hospital as well. And Sarah has a keen interest in scanning complex congenital heart disease.
Thank you, Hannah, and thank you, Pete, for that. I'm just going to see if I can share my screen for you. So my talk for you this evening is going to be it's going to follow on from Dr. Lilitos, and I'm going to show you more from an echo point of view, what hypoplastic left heart syndrome looks like in that postnatal period, all the way through to Fontan completion using transthoracic echo. So in terms from a sonographer point of view, what's our aim of the transthoracic echo in that immediate postnatal period? Well, first and foremost is we want to confirm that antenatal diagnosis of hypoplastic left heart syndrome. And we'll do that using something called the full sequential segmental scan protocol. And this not only allows us to confirm that diagnosis of hypoplastic left heart syndrome, but it also allows us to assess for any other associated anomalies. We'll then go on to make a rapid assessment of that patent ductus arteriosus and for the atrial septal defects. And I'm going to talk about that in a little bit more detail in a few slides' time. Once we've done that, we'll assess the left heart structures themselves in terms of the size of these structures. And we measure these and index them to the size of the baby with something called Z scoring. And then we turn our attention to the right side of the heart, in particular, as Dr. Lilitos said, looking at the tricuspid valve for the presence of regurgitation and assessing the right ventricle for its size and function. So my colleague Jan has shown you what hypoplastic left heart looks like antenatally. So what do we expect to see postnatally on echo? So this is an apical 4-chamber view. It's the same view. I wasn't sure if we had any paediatric sonographers on the course. So I've got the adult orientation and the paediatric orientation. So please use whichever one suits you. But essentially what we typically will see in hypoplastic left heart syndrome is a very small left-sided heart structures. So as you can see here, we've got a small left atrium, which is connected to a very abnormal mitral valve. In this case, it's thickened and dysplastic. It's trying to open, but it's not really. And that can vary. As Jan said, we can have something called mitral atresia, where the mitral valve's not formed at all. And then if we look at the left ventricle, now we're all used to seeing in a normal structured heart that the left ventricle is the dominant ventricle and therefore will form the apex of the heart in the 4-chamber view. But what you can see here is that it's actually the right ventricle that's a dominant ventricle and now forms the apex. And that's because the left ventricle hasn't formed properly, so it's what we term hypoplastic and small. And it's worth mentioning we can get varying degrees of how small the left ventricle is. In this case, we can see that there is a small cavity here and the rest of the ventricle is hypertrophied, trabeculated and poorly functioning. But in some cases, it may be difficult to even appreciate a left ventricle at all. It can be that small. And then our next step as sonographers is we're going to pop a little bit of colour on the mitral valve. And what we want to see is there any forward flow across the mitral valve? And is there any regurgitation as well? Because again, this can vary case by case. In some cases, we'll have absolutely no forward flow and we'll have no regurgitation. But as we can see on this clip here, we've got a tiny, tiny flash. You can just see this red flow here. That's a tiny bit of forward flow and we've got a small amount of mitral regurgitation. And then as we come up to the 5-chamber view, again, you appreciate how small this left ventricle is. We've barely got an LV outflow tract here. And this region here is the ascending aorta. And again, this is what we term hypoplastic, which just means small. And I don't really can appreciate this region here is the aortic valve. And again, similarly to the mitral valve, it's thickened, it's dysplastic, and it's not opening. And when we look at the colour flow mapping, again, we want to assess the same thing as the mitral valve. Is there any forward flow and is there any regurgitation? Now in this case, there's absolutely no forward flow coming from that left ventricle across the aortic valve and there's no regurgitation. But as I said, that varies case by case and our role as sonographers is to document whether there is any. So then as we come round to long axis, what do we expect to see? Well, we can again appreciate the small left ventricular cavity and we can measure it and index that to the size of the baby. We can also assess the mitral valve again from here. And again, you can see it's very abnormal. It's thickened, dysplastic. It's not really opening. And importantly, from the long axis view, we can assess the size of the aorta and again, index that to the size of the baby. And on the right-hand screen, we've zoomed in on the aorta and we've even dropped the colour scale down on our colour Doppler because we're really trying hard to see if there's any forward flow coming out of this left ventricle up the aorta. And again, you can appreciate that there really isn't any forward flow coming into this aorta. So then if we come round to the short axis view, again, we can appreciate from here how small that left ventricle is in relation to this dominant right ventricle. It's an excellent view for looking at the RVH and the radial function of the right ventricle. And then the other thing I'll mention from an echo point of view that we see in hypoplastic left heart that's very different to a normal structured heart is the aortic arch. So what we have on the right-hand side is an arch view. Again, it can be slender or hypoplastic, but most importantly, the flow within the arch is very abnormal to what you're used to seeing. And we have what we call retrograde flow in the arch, and that's this red flow coming up here. And if we think the reason why we have this, if you remember the earlier views from the aortic valve, we have absolutely no forward flow coming into the aorta. Therefore, the only way blood can get up to the upper half of the baby's body and down to the coronary arteries is from the duct. Now, the duct will sit in this region under here. You can't see it on here, but the flow comes into the duct and then it'll retrogradely fill up the aortic arch and give oxygenated blood to the upper half of the baby's body. And then the ductal flow will come in here and also antegradally go down the descending aorta to supply the oxygenated blood to the lower half of the baby's body. So this is what we expect to see in a hypoplastic left heart. So once we've made this diagnosis and confirmed that antenatal diagnosis of hypoplastic left heart, there are two connections that we as sonographers then have to make a rapid assessment of. And those are the atrial septal defect and the PDA. So I've done a little video for you to show you why these are so important to just show you here. So we have the pulmonary vein flow comes into the left atrium, it can't go anywhere. So we need the oxygenated blood to get across to the right side. So we need the ASD. And then we need to get the oxygenated blood back into the aorta to give oxygen to the baby's body. And this is through that PDA. So we need to make rapid assessment of the ASD and rapid assessment of the PDA. So how do we do that on echo, and what do we want to see? So we'll start with the ASD. So what we want to see is something that we term an unrestricted ASD. And all I mean by that is that the ASD is generally a large defect, and it allows for appropriate levels of oxygenated blood to get across to that right side. Conversely, if we have a defect that we term restrictive, generally that means that the atrial septal defect is very small and we can't get enough oxygenated blood across to the right atrium. And as Dr. Lilitos has said, this can be life-threatening for the baby in this immediate postnatal period. So our goals of sonographers is first and foremost identify how many atrial septal defects there are, because there may be more than one, where they are positioned within that atrial septum, and whether they are restrictive or unrestricted. So I'm going to show you what we mean by that on echo. So this is a subcostal view, and we've got here is your left atrium, right atrium, and you can see here the atrial septum. We have a very large secundum ASD, and you can appreciate on the colour flow here that there's no turbulent flow across this septal defect, and you can see it's predominantly left to right flow, but there is occasionally right to left flow, so it's a bidirectional shunt. And then if we do spectral Doppler across, what you can see here is that it's a very low velocity shunt. So this is well under 0.5 meters per second. You can see that little bit of right to left flow there. So if we see this Doppler pattern coupled with what we see on colour flow mapping, we would term that an unrestricted ASD. And that's what we want to see in hypoplastic left heart syndrome. Conversely, if we see something like this, you can immediately see that there's a significant difference between this atrial septal defect and the one I've just shown you. So if you look at the image on the left without the colour, you can see the atrial septum looks very different. So it's very, very aneurysmal. It's bowing across to that right atrium. And then with the colour Doppler, you can clearly see here that we actually have two defects, one here and one here. And they're both significantly smaller than the unrestricted ASD I've just shown you. And strikingly, the colour Doppler is very abnormal. So you've got this very turbulent flow, and that's suggesting we've got a higher velocity across this defect, and it's purely left to right flow. And if we put the spectral Doppler on, what we will see is this pattern here. So it's this continuous sawtooth pattern. And if you look at the velocity across this defect, it's significantly higher than the unrestricted one. So this is over 1.6 meters per second. And if you remember on the unrestricted, it was well under 0.5 meters per second. So then as a sonographer, if I see this Doppler pattern coupled with what we're seeing on 2D and colour flow mapping, we then need to do pulmonary vein Doppler, because it's this Doppler which will confirm whether this atrial septal defect is restrictive or not. And the reason for this, on your pulmonary vein Doppler, to confirm whether the ASD is restrictive, is you'll get this prominent A wave. And the reason why we get this, if we think about the blood flow in this setting, is you've got your pulmonary vein flow coming into your left atrium. It cannot get across the mitral valve. And we're now saying that the ASD is too small for the blood flow to get across to the right atrium. Therefore, as the atria contracts, we get flow reversal back up the pulmonary veins, which gives us this really prominent A wave. So if we as sonographers see this on echo, coupled with the images on 2D and colour flow mapping, that can be life-threatening for the baby, and we would need to flag that for the clinical team for them to come and assess the baby for us. So because this is such an important communication, I'm going to go through where we get the imaging of ASDs and how. So there's a couple of views that I like. So the off-axis apical view I like in older children and adults, especially if the subcostal views are suboptimal. And to obtain that, you're just going to get your standard 4-chamber view that you're used to all getting, but you're just going to bring your probe immediately towards the patient's sternum, and it'll swing the image around so the atrial septum's more perpendicular to your ultrasound beam, and it allows for better interrogation with colour Doppler. But by far the best views are your subcostal views. So that standard long axis view that we're all used to getting, where you've got your 4 chambers in, but importantly, a view called the bicaval view. Now, this might not be a view that everyone is used to getting, so I'm just going to go through how we get this view. So you get your standard long axis view and rotate round to your IVC view like you normally would going anti-clockwise. But as you do that, you're going to angle the probe footprint up to the patient's right shoulder, and you'll bring in the SVC here, which is that red flow. The atrial septum is between the SVC and the IVC. It's worth mentioning, if there's any pediatric sonographers on the call, you will invert your up and down, and you will rotate clockwise rather than anti-clockwise to about 5 o'clock. But you're still going to angle your footprint up to the patient's right shoulder to bring in the SVC. So that's how we assess the ASD. And I will say from now on, this is a communication we have to assess for the entire lifespan of a patient with hypoplastic left heart syndrome. Because as I said, without the ASD, we can't get the oxygenated blood across to the right side. So once we've assessed the ASD, we want to move on and have a look at the PDA. So again, we're going to turn what we want to see is an unrestricted PDA, and it's very similar to what we've talked about with the ASD in the sense that we want it to be a large defect, a large PDA that's bidirectional flow. There's no narrowing at the PA end of the duct and no narrowing at the aortic end of the duct. Now, I will mention is by the time most of sonographers go to scan these patients, the duct will be large and unrestrictive. And that's because, as my colleague said, most of these get diagnosed antenatally. They're the first thing that happens is the baby starting unprosting, and that will keep the duct open and unrestrictive. So it's quite rare for us as sonographers to come across a very restrictive duct in this setting. So this is what we want to see with a duct. So what you have here is the main pulmonary artery, right pulmonary artery, left pulmonary artery, and this structure here, that's your PDA, and then that's the descending aorta. And you can see on echo that we've got bidirectional flow. There's no significant narrowings at either end of the PDA. So this is what we want to see, and it's what we term an unrestricted PDA. So once we've confirmed the diagnosis, we've made sure the baby's safe with an unrestricted ASD and a large unrestricted PDA, we then need to have a look at the right side, because as Dr. Lilitos has said, this can impact on what surgeries we can offer for these patients. So in particular, we want to look at the tricuspid valve for the presence of regurgitation and quantify that. I'm not going to go through how we quantify it because it's the same as what you're all used to doing in your standard practice, but I will mention that from now on, through all the stages of Fontan into adulthood, this is something we have to assess and document whether there's a change over time with the amount of regurgitation that's there. So then the other thing I want to say about the right heart is the right ventricle itself. So as Dr. Lilitos said, it's something that we call a systemic right ventricle. And all we mean by this is that the right ventricle is now pumping the blood around the body. So it's acting like a left ventricle rather than pumping blood to the lungs. So we know the right ventricle is not designed to do this. So over time, it will dilate, it'll become hypertrophied, and it will become impaired. So we need to make careful assessment of the RV function. So how do we do that in this setting? Well, we're going to use the same things we're used to doing in normal structured hearts. So you'll use your TAPSes, your RVS primes, your free wall strain, your fractional area change, etc. But what is different in this setting is that the numbers that we all know of for a normal right ventricle don't apply in the setting of a systemic RV. So what we need to do is make more of a serial assessment, and is there a change in the numbers? So it's not so much what the numbers are, it's whether they've changed over time. So for example, if the TAPSE on the previous scan was 1.6 centimetres and now it's 1 centimetre, that's telling me that we've had a significant change in that longitudinal function of the systemic RV. So not only will we do these quantitative measures, we also need to do a visual assessment. So what we will do as sonographers in our centres, we'll visually compare the previous images versus the images that we've just taken, and we'll do a visual assessment to see if the RV function's changed. So from now on, this is something we have to assess every time we scan these patients, so right through from childhood into adulthood. So just bear that in mind as we go through all the stages. This is part of each stage that we've got to assess. So once we've done all of this, the baby's been accepted for surgery. They then go on to have, as Pete said, the Norwood stage 1. Now, due to time constraints, I'm just going to talk you through from an echo point of view what we do in our centre, which is the Norwood stage 1 with Sano. But bear in mind, there is the BT shunt and there is the hybrid procedure. So in terms of echo, what's our role? So after they've had the surgery, we're going to assess the ASD like we've done before, making sure it's still nice and unrestrictive. We no longer need to worry about the PDA. That's been ligated by the surgeons. What we now need to assess in particular is something called the Damas-Carl-Stanzel connection, or Damas for short. And that's where we have connected our native hypoplastic aorta to our new neo aorta. And we need to assess this Sano shunt, this RV to PA conduit. So what do these look like on echo? So we'll start with the damus. So this image on the left is a diagram I've done that just shows you the equivalent echo view. So this is a parasternal short axis view where you would normally go for your pulmonary valve, but we label things very differently now because of the surgery. So this was the pulmonary artery, but as Dr. Lilitos said, we've disconnected this from the branch PAs and directly plumbed this to the aortic arch and descending aorta. So we now label this our neo-aorta because it's acting as an aorta. So therefore, we no longer call this valve the pulmonary valve, and we call it the neo-aortic valve. And perhaps what's the most important is this connection here. So this is the damus connection. So this is where we've connected our native hypoplastic aorta to our new neo-aorta. You can see it on the right-hand side there. And the reason why this is so important and we need to make careful assessment is because if we remember from the earlier pictures, we have no forward flow across our native hypoplastic aorta, but we know the coronary arteries stay where they are, so they're still coming off the native hypoplastic aorta. So the only way for us to get coronary artery perfusion is through this damus connection. So we want to see forward flow across the native aortic, neo-aortic valve, and we want to see retrograde flow coming across this damus connection into our native hypoplastic aorta. So if we put colour on, this is what we want to see. So you've got the forward flow coming down through the neo-aortic valve into the neo-aorta, and just at the end of that arrow, you can just see a flash of red, and that's the retrograde flow coming across the damus into our native aorta. And just a word, in older people and adults, you might need to zoom in on this region. You might need to drop your colour scale Doppler down as well to appreciate the flow in this region, in particular if we're trying to see it into the coronary arteries. But what we don't want to see is highly turbulent flow across this region. We want nice laminar flow, because as I say, this is what is now maintaining coronary artery perfusion. So the damus connection is now something, once they've had this procedure done, something we have to assess for the entire lifespan of a patient now. So that's the damus. As we know, as a stage 1, we also do something called the Sano shunt. And the Sano shunt is essentially an RV to PA conduit. It generally is unvalved, so there's no leaflets in it. So what we expect to see is antegrade flow coming out of the right ventricle to the branch PAs, and then we'll have diastolic retrograde flow coming back into the right ventricle like regurgitation. And the goals of sonography is to assess this Sano shunt at the proximal region, just as it leaves the right ventricle. And you can see on the colour that you've got the antegrade flow coming out and you've got the blue flow coming back in, which is the retrograde flow. We'll also pop a CW in this region to get the Vmax, and I'll explain about that a little bit later on. And then on the right-hand side of the screen, we want to track the Sano shunt along its length. So this is the mid region of the Sano. Again, you can appreciate the antegrade and retrograde flow, and we'll also pop a CW in that region as well. And then what we'll do is come around to get the distal region of the Sano. So the distal Sano is this region, and that's where it's connecting into the branch PAs. Again, we'll pop CW in this region of the Sano, but also from this view, we like to assess the size of the branch PAs and also the flow within them. The other thing to mention, with it being a man-made structure, you can develop thrombus within the Sano shunt. So we like to do a careful assessment visually to see if we can see any thrombus formation. But this is where your Doppler can help as well, because it can be difficult to image the Sano. So this is what we expect to see with the Sano shunt in terms of Doppler. So it's a high velocity shunt. So we expect it to be around 3.5 to 4 meters per second. And I've got 2 examples here because it does change. So this is the proximal region. So we expect from the proximal region that comes out of the RV, it'll come towards our probe. So the higher velocity will be coming towards us. And then the diastolic retrograde flow is going away from us back to the RV. Whereas the distal and mid region, the antegrade flow will be going away from us towards the branch PA. So it'll go below the baseline at this, and then that's your retrograde flow. So the reason why we Doppler at multiple levels is we're looking for a change in velocity. So say if it was 3.7 at the proximal region and then the distal region, we got 4.7, that's telling me there's a significant change going on within that Sano. And it might be there's some narrowing due to thrombus, or it's just starting to narrow is that Sano. And again, that's something as a sonographer we'll just document for the clinical team, because it might be the patient needs to go and have a stent to open up the Sano and maintain that flow to the lungs. So that's an overview of the stage 1. And then as Dr. Lilitos said, they move on to the stage 2. So that's where we bring in a Glenn shunt. So what do we do on echo? Well, we're going to assess everything we've just discussed for the stage 1. So that includes reassessing the ASD, assessing that DKS, assessing the right heart. But importantly now, we no longer have the Sano shunt, that's been removed, and we now have the Glenn shunt, which is where we've disconnected the SVC from the right atrium and directly plumbed it into the branch PAs. So how do we image this on echo? Well, there's a couple of views that I like. So the first view is this one. This is the suprasternal notch view. So it's where you would normally go for your arch view. You're just going to rotate round to 3 o'clock. And what you bring in is the aorta in short axis, and then you have your nominate vein running over the top. This is your SVC coming down the right side of the aorta for a right SVC. And you've got the Glenn anastomosis to the branch PAs. Now, of note, this shunt is now a low velocity shunt. So we're talking in the realms of 0.2 to 0.3 meters per second. So we can develop thrombus within this region. So we need to make careful attention on the 2D image to see if there's any thrombus. You may get spontaneous contrast, that can be normal, but we just want to do is check to see if there's any thrombus anywhere within this region down here. We'll then put the color on. And again, you can see here, we've had to drop the colour scale down to appreciate the flow, and that's because it's a low velocity shunt. But what we want to see is we want to see flow all the way from the SVC into the branch PAs, both the LPA and RPA. And we'll put a Doppler down here, and I'm going to show you what the Doppler looks like in a minute. So that's the suprasternal notch view. And then there's another view that I like, in particular in older children and adults, where it's more difficult to get that suprasternal notch. And it's the right side of the neck for a right-sided SVC. So as you can see in the middle there, you put your probe just on the right side of the neck with your dot at about 12 to 1, and you angle across. I like colour compared to help you spot where the SVC is. So this is your SVC here, this is where the Glenn anastomosis is, and this is the branch PA region. And again, we want to make careful assessment for the presence of thrombus within that region, and then put some colour Doppler on. And what we want to see is blue flow, because it's going away from us down the SVC to the branch PA, so it should be blue flow going away. And you can see here it's phasic, and what we mean by that, it's in time with the patient's breathing, because this is now linked to the patient's lungs. And again, we're going to put a Doppler down here, and this is what we expect to see. So you can see here, when it's doing this, this is the phasic nature of a Glenn. So this is in time with the patient's breathing. It's a very low velocity, so as I say, about 0.2 to 0.3 meters per second. So that's an overview of your stage 2. And bear in mind, the Glenn now stays. So we have to assess the Glenn from now on all the way into adulthood, the way that we've just described. So once they've had their stage 2, they will eventually, about 3 to 4 years of age, go on to have the Fontan completion stage 3. So again, we now assess everything we've just discussed. So again, the ASD, that Damus connection, the Glenn, but now we've got an added connection, which is that total cavo-pulmonary connection, or TCPC for short, which is where we've essentially just disconnected the IVC from the right atrium and plumbed that into the branch PAs. So where do we see this on echo? So my favourite view is actually the subcostal view. So you go your subcostal view where you normally go for your IVC, and you can see the IVC here, and instead of it draining into the right atrium here, we see it dive away from us. And this structure here is the TCPC. And again, this is a low velocity shunt. So again, it's going to be around about 0.2 to 0.3 meters per second. So again, we're prone and at risk of developing thrombus. So we need to make a careful assessment to see if we see any thrombus in this region. We'll then pop colour on here again. We'll see that it's phasic, because it's linked to the patient's lungs now. It's not connected to the heart at all. And again, we want to see the blue flow, because it's going from the IVC down from here into the TCPC and off to the lungs. We'll put a Doppler in, and it'll also look the same as the Glenn, so it'll be phasic in nature and low velocity. The other view that I like is the apical 4-chamber view. And what you'll see behind the atria, you can see that circular structure, that's the TCPC. And again, it's a good view for looking and assessing for thrombus, but probably most importantly, it's really good for assessing for the fenestration that Dr. Lilitos mentioned. So you can see here, we've got this red jet, that's the fenestration from the TCPC into the atria. And as sonographers, we can do a mean gradient across this, which helps the clinicians look at the pressures within that Fontan circulation. So if we put Doppler across, we'll get something like this. And then what we actually do is we trace over this Doppler pattern over 3 to 4 cardiac cycles, and we'll generate a mean gradient. And we will quote this in our report. And again, it's something that we check to see if it changes over time. Now, it's worth mentioning, not everyone has a fenestration, and some of these fenestrations we will close over time as well. So as sonographers, it's worth checking before we do a scan whether the patient actually has a fenestration or not. If they did have a fenestration and we can no longer see it on our echo, then we need to make really close assessment to see if there's any thrombus within this region, because it might have blocked off the fenestration. And again, that's a bit of a red flag that we just flag up to the clinical team. So that's a real whistle-stop view of hypoplast in that immediate postnatal period all the way to Fontan circulation. So has anyone got any questions for me and Pete?
Thank you very much, Sarah. That was brilliant, and thank you very much, Pete. So we do have a couple of questions that have come through. So this might be more aimed at yourself, Pete. It was just if there is much of a difference between having a BT shunt and a Sano. Is there any reason why some patients get a BT shunt and some patients get a Sano?
Great question. So the reason why some might get Sano or some might get a BT shunt, where primarily it's surgeon experience and surgical preference. So it depends which center you work in. And some surgeons are more used to doing BT shunts, so they stick to what they know they do best, and they'll get a better outcome, vice versa with a Sano. Physiologically, a Sano generally offers more stability after the placement of the shunt. That's because the connection from the right ventricle directly into the pulmonary artery through this prosthetic conduit offers some diastolic, end diastolic pressure. So your regurgitant flow back into the RV is generally less. If you've got a systemic arterial to PA shunt, so BT shunt, which is connected generally from the innominate artery into the pulmonary artery, the PA doesn't have much diastolic end diastolic pressure, so you're more likely to get flow reversal, systemic steal down the PAs, which can cause post-operative hemodynamic instability. So generally, the consensus is that a Sano for connection from the RV to the PA offers more hemodynamic stability compared to a BT shunt. But in terms of which one you get, it's often down to surgical experience in the center you're working at.
Thank you very much. Another question that's come through is, what echo parameters do we use to assess borderline LVs, and what determines it? Is it actually a hypoplast, and what's just a small ventricle? Is there anything you can do to decide whether it's classed as a hypoplast or just a small left ventricle?
I'll start off on that one, Pete. So from an echo point of view, we do quite a lot of measurements. So we'd measure like the mitral valve annulus, the LV length and the size of the left ventricle, and the aortic valve annulus and the size of the aorta, and we index that using Z-scores to the size of the baby. So we take the weight of the baby, and there's normal ranges for this. And I think they also go through a rigorous MDT as well, where everyone looks at the images. And I think, Pete, from a clinical point of view, do you have a clinical assessment as well on these babies? So not just from an echo parameter point of view.
Yeah, well, so certainly echocardiographically is sort of a lot of weighting on that for determining whether it's going to be a biventricular or a single ventricle. Essentially, is the LV going to be apex forming? A general rule of thumb: if you've got a narrow but long LV that's apex forming, that might do. Whereas if you've got a short, fat, stubby LV, that generally doesn't do. So that's a sort of general rule of thumb. It really it depends, on how the baby's doing clinically, whether there's been any atrial restriction as well, during fetal development and all those sorts of things. But we do, I think, Sarah, we generally rely heavily on the echo data to help us determine that.
Super, thank you very much both. We do have a couple more questions, but we will move on, and then we can always come back to them and answer them later on. So up next, we have Dr. Helen Parry. She is a consultant in adult congenital heart disease, and she has a special interest in echo. She is BSc accredited in TTE and EACVI accredited in congenital and TOE. So thank you very much, Helen, for presenting this evening.
Hi everyone, thank you very much, Hannah, for inviting me to present. And thank you to my co-panelists, because you presented a really nice talk. So hopefully we can bring some of it together and move towards adulthood. So we're just, there we go. So as Hannah says, my name is Helen Parry. I'm one of the consultants here at Leeds. I also work at the Northern General Hospital. With my colleagues there, we do the ACHD service in Sheffield too. So we'll talk about our current experience with hypoplastic left heart syndrome. I'll look at some case studies and we'll highlight common complications such as right ventricular systolic dysfunction and tricuspid regurgitation. We'll talk about some features that are echo unique to these type of patients, such as fenestrations in the Fontan circuit itself and the Damus, which Sarah's already touched on, so it'll be just emphasising that. I'll also briefly talk about some of the non-echo clinical implications, because it's really a multi-system pathology, and it's really important to bear that in mind, as Pete touched on. So the current state of play, certainly here in Leeds, is that we have relatively few adult patients with hypoplastic left heart syndrome at this point, and it is expanding. Currently, our oldest patient here in Leeds is in their early 30s. It's likely that this population will increase significantly over the next 2 to 3 decades, as surgeons are becoming more and more familiar with these surgeries. Hypoplastic left heart syndrome is a range of anatomies and involves a range of different operations that have been done. Not every patient will have the classic Norwood 1 to 3. Some won't get past Norwood 1. And some of them will have slightly different approaches, because, of course, you could have a hypoplastic left heart as part of another spectrum as well. So how do you approach scanning? Well, you tailor it to the anatomy. As Sarah said, it's great to start off with your subcostal view, and then you can orientate yourself. You've got an idea where the atrial inflow is coming from. You can look for intertatrial communication, and you'll have your situs from there, and you'll know if the patient has levocardia, dextrocardia, and you can proceed accordingly. You would want to assess the patency of the Fontan circuit, including the fenestration if it's there. Atrioventricular valve regurgitation is vital, important to assess ventricular function, outflow from the ventricle. We've already mentioned that it's very important to assess flow through the Damus or the DKS, and the aorta, near aorta arch and descending aorta. So exactly as you would normally approach any congenital patient, go all the way through the connections until you're going back around in a circle or an 8. So this will be very case-based. My first case is a 21-year-old who was born with hypoplastic left heart syndrome, and he had Norwood 1, 2, and 3, and has a fenestrated Fontan. And here are his images. So we can see this is the IVC. It's a similar view to the one Sarah showed you, but it's not as clear as Sarah's. And I think that's something that's important to remember, that actually often structures that you can see really beautifully in pediatric patients are harder to see in adult patients. And that's because this distance is often significantly greater, particularly things like subcostal views. You do have the advantage that they don't tend to jump around as much, although that does vary. So this is an apical view. So we can see that this is a right ventricle, because we can see the increased trabeculation, and the fact that it's appropriately dilated because it's a single ventricle has really brought out that trabeculation. We can also just about make out this moderator band here. And we can see the AV valve, and right at the bottom of the screen, we can see the Fontan connection. Sorry, the Fontan circuit end on. Okay. So have a look at that before I show you anything else, and just have a think to yourself what you think of that function. Sorry, this is a little juddery, bear with us. So we can see there's significant regurgitation through the atrioventricular valve. So I would grade this as moderate, and the person reporting it graded it as moderate, but hopefully I'll convince you of that when we look at it in different views as well. And as Sarah said, the way that you assess it is exactly the same as you would any AV valve regurgitation, and you use the same parameters. You might notice that the scale is turned down a bit lower than we normally would. For assessing AV valve regurgitation, you'd normally have it in the 60s or 70s. But what that does give us the advantage of doing is seeing the flow in the Fontan circuit. Okay, so Sarah's already mentioned the way that we assess right ventricular function is very similar to how you would assess it in any other patient. However, as she's also said, it's more about change than absolute values. I would say they're almost never normal, or they might be lower end of normal. So it's really the change that we're interested in. So that was the RVS prime that I've shown you. This is a slightly distorted image of strain. As we all know, for strain, I can't give you values that it should or shouldn't be because it varies dramatically with manufacturers. So that's something that the change is more important for every patient, not just for patients with a hypoplastic left heart. So the RV in a hypoplastic left heart is harder to assess than an LV would be in a normal heart. Obviously, the geometry is different, the perfusion is different, the perfusion of the RV is different in hypoplastic left hearts. It will look different and your measurements will be different. TAPSE, RVS prime, fractional area change, strain, and right ventricular ejection fraction based on 3D volumes have all been published as useful in HLHS, but actually it's change that relates to poorer prognosis rather than the absolute measurements. There's also some evidence that tricuspid inflow parameters reflecting diastology could relate to prognosis. So if you notice a change in your Doppler through the tricuspid valve, that can also be helpful. So back to my case, you can see here, there's flow in the Fontan circuit here, and we can just about make out the little fenestration there. And again, you'll probably pick up that it is harder to see in adult patients. I did try and find ones that were as clear as possible, but it is harder to see, but you can definitely pick up that turbulent flow. You'll notice the scale is still down around 50, and I think that's a good ballpark for looking at the Fontan circuit and trying to help there. Sometimes you might need to turn it down a little bit more. Okay. Sorry, I think it's just replaying the same one, and we'll move it along. There we go. This is me being impatient. So again, this is a tracing through the fenestration. The mean peak pressure is a little bit higher than the one that Sarah showed you, slightly older patient. I would say it should be less than 5 millimeters of mercury as a mean. So we're about there with this one. And like Sarah said, you do it over a few cardiac cycles. So fenestrations, what's the point of them? Well, they reduce central venous pressure, which is high in a Fontan circulation. They also improve systemic preload because you've got that direct communication with your systemic atrium, then ultimately ventricle. And they also avoid excessive pulmonary blood flow and avoid increases in pulmonary vascular resistance, which we know we want because we don't want to develop pulmonary hypertension. However, they do cause patients to desaturate. It is essentially a right to left shunt that you've created. So your saturations will be lower with that fenestration in. And they're also a route for systemic thromboemboli. So patients with the fenestrations are more likely to have strokes, other systemic vascular events. And that's worth remembering because it is a risk as they get older. So they're often closed in the early pre-transition, in the late pre-transition or early post-transition period. However, it's not the right thing to close all of them the saturations don't always improve if they're closed, because there may be multiple reasons why the saturations are low. We've talked about lung pathology being very common in this group. We've also talked about increased risks of pulmonary vascular resistance in these groups. So it's not always beneficial to close the fenestration. So back to my case, this is the outflow. So kind of equivalent of a 3-chamber apical view, and this is the neo aorta, but we see it much better parasternally, so we'll move on. So you'll recognise this as close to a parasternal long axis view. So you can see, actually it's really hard to see the native aorta there, but the next couple of pictures you'll see it more clearly. This is the neo aorta, which you can see is dilated looking, and that's because it's receiving the whole of the cardiac output. You also get more of an impression of the rudimentary LV coming in than you did in the previous apical views here. This is a short axis view, and you can see that in this patient there's very small hypoplastic left ventricle. And looking at this view, I felt that I was less convinced about how good the ventricular function was than I was when I was looking at the 4-chamber, well, the equivalent 4-chamber view. Obviously there's not 4 chambers. So it's just worth, as always, bearing in mind, reserving judgment until we've seen all of them. It also looks like it's on the AVSD spectrum. You can see that this is not normal tricuspid valve, and they're at the same level. So there might be other subtleties when you're scanning these patients. This is the descending aorta, obviously really important to assess. Patient may have had a coarctation early in life, so it's quite important to assess those. And this is that right-sided supraclavicular view that Sarah was showing you, which I agree is the easiest one to see the Glenn shunt in. And you can see this is nice laminar, low velocity flow. And again, we've got the scale down at around 40. Great. And that's tracing through. So we are just above the 0.3 meters per second there. Which is the absolute highest that we got, and mostly it looked a bit lower than that. So case 2, I've not put the age in. My next case is actually a 16-year-old patient with neonatal coarctation repair and an aortic valvotomy, who had a Norwood 1, so has a Damus case standstill, or we call it a Damus for short, or a DKS, had an initial right BT shunt, subsequently a left one. But the pulmonary pressures were too high to proceed to the Fontan circulation. So it wouldn't have worked. It wouldn't have been that nice dependent flow down the pressure gradient. It would have not perfused the lungs properly. So here again is our subcostal view, where we can see the inflow from the IVC is less clear, hepatic veins is more clear here. And then moving on to the apical views. Sorry, I should have said from the subcostal views, you can tell the cardiac orientation, so you know where you need to look for your apical views. So unfortunately, it is playing a little bit jerkily, but I hope we can appreciate. In fact, I'll go back and see if I can play it another way and see if that works. No. So unfortunately, it's not coming across quite as nicely as it did before, but you can see that this right ventricle is really, really, really struggling. It's dilated. You can see those trabeculations, which is fine. It can be dilated. It needs to be dilated. It's supplying all of the cardiac output, but it's just not moving very well at all, and it's really struggling. And you can see that there's little diminutive left heart there. Sarah had mentioned to you throughout life, you need to assess C into atrial communication. And you can see that that's widely patent here, that's no problem. But what is a problem is that there is significant tricuspid regurgitation, and I would describe this as borderline severe, if not severe, and I'll hopefully convince you as we go along that that's the case. You can also see, in terms of the etiology of that, it's quite a central jet, and that's because the function is so poor that that the leaflets are quite tethered, and again, it's very dilated. Sorry, there's just a slight delay when I move it along. It's not that I'm suddenly getting quiet, I promise. Okay, so that's the inflow through the tricuspid valve. And again, you can see relatively high velocities for that equivalent E wave. And this is your standard peristernal long axis view. So we can see this tiny, maybe if I take my cursor off, that's better. That tiny mitral valve is hardly opening. You can see the knee aorta there, and you can see that dilated right ventricle. Okay. And this is actually the best example of a Damus connection that I could find in all of our adult patients. And we can see that this is the knee aorta with blue flow coming down and red flow going into that native aorta to supply the coronary arteries. It's actually quite hard to see in adults as nicely as it was in Sarah's. I would say you can normally see it. It just doesn't look quite as pretty as it does in the kids. But this was the best example I could find. You can see there's just a whiff of new aortic regurgitation there. Okay. So this is a modification of that view. And the reason that I've shown it is we're just about getting the BT shunt here. It was incredibly difficult to see on this patient, which it often is. This is a typical kind of shunt-like trace in that it's continuous flow, but it's phasic. I wouldn't pay much attention to the velocities because we're not catching it in good alignment, but it's just an example of how it looks. What I would say with the shunts when you're scanning is if you've seen it clearly and you've got a good trace, document exactly where you got it. We had a case just the other Friday where I'd spent ages, I thought, looking absolutely everywhere for a shunt in one of the hypoplastic patients who actually stopped at a central shunt. And I just couldn't find it. And I asked Sarah to come and have a look. And she said, oh, have you tried right sternal edge, but with them on their left rather than on their right? And I said, no, I put them on their right. But when she did it on the left, there it was, which was great. So I've written in very clear letters on the report that that's where we found it most clearly. So shunts can be hard to find. If you find it, if you get a nice picture and you get a nice Doppler, just make a note on the report, just as you would for, in acquired scanning. If you get a nice trace of your aortic stenosis, you'd put, oh, best trace with non-imaging probe at suprasternal notch or similar, wouldn't you? So it's the same thing. Okay, so this is a parasternal image of the same patient. And again, you can see this right ventricular function is very poor indeed. It's not just the jerkiness that is making it look bad. It is genuinely very, very bad. And we can see that this left ventricle is small and not contributing. Okay. So in addition, just to highlight that hypoplastic left heart syndrome, whichever way you look at it, as a multi-system pathology, and Pete's already mentioned that it's really important to monitor many different things in these patients. Monitoring kidney function is vital. We know they're more prone to renal impairment, partly due to the medication, but partly due to renal underperfusion. The GI tract is also somewhere that we can see complications in its most extreme form. We can see protein losing enteropathy. but actually often it's a case of gut underperfusion, leading to poor appetite and weight loss. Lungs, again, we've talked about how securing blood flow to the lungs is really important, but we don't want to flood the lungs. Being careful of pulmonary pressures is very important. And one of the things that we always really dread patients developing, mainly in the adult world, is plastic bronchiolitis, which is one of the almost pre-terminal things that we can see in these patients, where people actually cough up little casts of their bronchial tree. In addition, the liver is really important. Patients' liver function often starts to deteriorate even after 5 to 10 years following their Fontan completion. So we are getting patients referred through now that even at their 16 pre-transition liver scan have already got significant hepatic pathology. And it is important because the liver can, it is important because pathology can range from a little bit of fibrosis to full-on cirrhosis or even hepatocellular carcinoma. And we've had more than 2 or 3 patients now who've ended up on direct chemotherapy into the liver as a palliative way of treating hepatocellular carcinoma. I put the genitourinary tract in, which is a kind of system way of saying pregnancy can also be a problem in these patients. As you might imagine, pregnancy in these patients does carry a significant risk, and you would want to optimize them as much as possible prior to conception. Even if they do conceive, there's no guarantees that they will be able to carry the pregnancy through to term, and that will depend on how well the heart is functioning, the degree of AV valve regurgitation. But even in a Fontan with relatively few complications cardiac-wise, there's very high prematurity rate and very, very high miscarriage rate. And I've put the brain in there as well. I think Pete highlighted that a lot of these patients have neurodevelopmental issues due to brain hypoperfusion in the early years, and it may be part of any sort of syndromes that are involved. But what I would also just want to really highlight is the strong psychological component, because actually you might have what looks like a great Fontan on your echo pictures, but the fact that these patients have spent so much of their young lives in hospital, they can be really badly psychologically damaged by it, and that can end up being a big part of the battle as they move through adult life, and they're a bit more able to remember things and a bit more able to argue back. So in conclusion, approach to scanning will vary with the anatomy. Standard values that you might get from measurement are not applicable in this context, but changes in them are important. Common themes are function of the ventricle, AV valve regurgitation, patency and flow in the Fontan or TCPC, assessment of the shunt, and looking for a fenestration. So these are the references. And I think we're probably all joining back together for questions.
Thank you very much, Helen. That was an excellent presentation. Thank you very much. So I think the plan is now there's quite a few questions that have come through. So feel free, anyone, to jump in and answer if you feel it's relevant to your topic and your talk. So I'll just go through them. So one of the questions, fetal related, was how do we deal with the fetal waiting list in these cases? So if someone could explain a little bit about sort of how it works with the referrals and
yeah, thank you. So we have a electronic referral system where we receive referrals from across the region, and we triage those on multiple times during the day. And essentially the NHS standards are that we see a suspected abnormality within 3 days of diagnosis. And those standards say 3 days, not 3 working days. So that means if a referral comes in on a Friday, we need to have seen that lady by the Monday. And basically we just do our hardest to see those patients, and we manage to fulfill those standards most of the time. So we have a fetal list every single day. We do 10 sessions during the week, and because of the level of having 3 fetal cardiologists and the sonographers supporting that service, we manage to turn that around pretty much all the time. Obviously, these patients are really anxious. They might have, just been told that they think there's an abnormality with the baby's heart. Sometimes people will have said to them that, they think the left side of the heart is small, so they might have gone and, looked on Google and kind of come with some ideas already. So you can imagine sort of anxiety levels are really high. So we basically see the patients within a couple of days of referral.
Thanks, Jan. Another one of the questions that's come through is what is the advantages and disadvantages of having a fenestration with a Fontan circulation, and why would this fenestration be closed?
Helen probably can both answer that from a paediatric and adult perspective. So the reason a fenestration is put in when the initial Fontan is done in childhood is to give somewhere for the blood to go. So it's like a blowhole. It's a blow-off valve, whatever you want to call it. So from the Glen, you've got the SVC into the PA, but then in the Fontan completion, you then connected the IVC into the PA. So all your systemic venous return is now going to the lungs. But that's all dependent on pulmonary vascular resistance being low. So if for whatever reason the pulmonary vascular resistance becomes labile, your blood flow stops. So it gives somewhere else for the blood to go to blow off, if you like, into the right atrium and maintain systemic output. So that's the main reason for keeping it. Sometimes you might want to close it if the patient's too blue, for example. That can have other side effects of raising your systemic venous pressure. I'll let Helen just elaborate further on why fenestration may be helpful or not helpful as they get older.
Yeah, so absolutely agree with you, Pete, in that the advantage is that it does act as a blow off and secures that systemic blood flow. It also helps protect the lungs against raised pressures. As patients get older, they tend to become more aware of the desaturation that's associated with the fenestration. So patients can have SATs in the high 80s, which some of them tolerate really well, but some of them, more active people, want to do more, and they struggle when they're trying to do more exercise because they're just not able to have their oxygenation. So a lot of the patients, you end up closing it just prior to transition or not long after transition. But I think if you do have concerns about the level of pulmonary vascular resistance, if there's lots of vena collaterals, then you would avoid closing the fenestration in that patient. So I think it depends on each individual patient. If they are struggling with significant desaturations, which a lot of them do, then we do close it. Hope that answers the question. But it is controversial. I went to a whole day on single ventricles back in September time, and one of the speakers said, "Oh, it's the first time we've not spent at least 3 hours discussing whether or not you should close fenestration." So this is what Pete and I think, but it is a controversial topic.
And probably last thing to say for the echocardiographer, fenestration is quite useful because it provides a window into estimating the pulmonary pressures, because if you say your RA pressure arbitrary is 5, if your mean gradient across it's 5, your PA pressure is probably about 10. So so it's from a technical perspective, fenestration can be helpful, but from a well-being perspective, sometimes it's as you get older.
Great. So another good question that's come through is, I know Sarah showed and highlighted how to image SANOs, but how do we assess a BT shunt on TTE, and which views would be best to assess a BT shunt?
So that's a really good question. So to understand where we get the images from, we need to understand where the BT shunt is. So the BT shunt, it comes off the subclavian artery and is connected to the branch PAs. So sometimes it can be quite difficult to see the shunt without using colour flow mapping. So I generally would say you want to do colour compare with your colour on. You're going to start from your suprasternal notch views and put some colour on towards the head and neck. And what you're looking for is a continuous high velocity flow going from the head and neck region, that subclavian artery, towards the branch PAs. What we then want to do is, another view that I like as you see it coming towards the branch PAs, is a high left parasternal view, where you're looking for the branch PA. So where you would normally go for your MPA and pulmonary valve view, move up a rib space, and what you'll bring is just the branch PA view. And you should, again, with colour flow, again, it's difficult to see it just on 2D. So I'd always suggest using colour compare, put your colour box on, and you're looking for a continuous high velocity shunt. So we're talking about 4 meters per second. And on Doppler, it looked like a sawtooth. And the goals on echo is to try and track it from that suprasternal notch view all the way down to the branch PAs. As I say, you're probably not going to see it in one view all the way from that proximal region to the distal. We're probably going to have to utilise a few of these views, the suprasternal notch views and a high left parasternal view, the ones that I would generally go for.
Thank you very much, Sarah. So another question, so it's just in relating actually to pregnancy, so this might be sort of more related to you, Helen. So how does pregnancy affect cardiac function in these patients, and is there anything we should be looking out for in echo?
So when you're scanning a patient who's already pregnant, or if you're kind of counselling, I suppose I could kind of talk about
Yeah.
Yeah. So pregnancy in this population is thought to be moderate to high risk in the absence of any complications. So I would say there's no patient with hypoplastic left heart syndrome that has no complications by the time they get to childbearing age. All of them will have some degree of AV valve regurgitation, and they'll all have some decline in their ventricular function even by then. However, more and more of these patients are becoming pregnant. There's very high rates of miscarriage at all points. And that's really difficult to predict. And it's not uncommon in patients who you actually think, oh, this person's actually a pretty good bet for it, a pretty good go for pregnancy. There's also a high chance of prematurity. In terms of what you see on the echo, it's very often the same as what you see in any case. So we know that the heart rate increases during pregnancy. We know that the cardiac chambers dilate during pregnancy. We know that if we've already got valve regurgitation, it will likely get worse during pregnancy. So these are all of the things that we look out for. It's also a prothrombotic state, and very often it's difficult to anticoagulate these patients properly during pregnancy. So looking out very carefully for thrombus is super important, because you can't have warfarin during pregnancy. The DOACs that we like to use are not well tolerated during pregnancy, and low molecular weight heparin is just not as good as warfarin or the DOAC. So looking out for thrombus is really important as well. And non-echo thing that's a common issue in pregnancy is any form of arrhythmia is incredibly badly tolerated. It's badly tolerated in this group anyway, but if they're pregnant, it's just, you need to cardiovert them straight away. Otherwise, that may well be it for them, unfortunately. So it's tricky. I prefer they just bought a POP plan rather than have kids, to be honest.
Thank you very much. We do have quite a lot of questions coming through, so we will try and answer as many as we can. For the question, someone's asked, with severe systemic AV valve regurgitation cases, what treatment options are available, and are any catheter valve interventions possible? I guess it probably varies slightly, doesn't it, between what stage these patients are getting severe AV valve regurgitation?
Yeah, absolutely. So in terms of things like mitral clip and tricuspid clip, then I've never known them used in the context of a single left ventricle. So at the moment, no, but you can see it going that way. In terms of options, we have certainly done equivalent mitral valve replacements and Fontan circulations, but it's not done commonly. We've also done valve repairs in this population. Again, it's not done all that commonly, but we have had some good results. The only percutaneous intervention to a regurgitant valve I can think of off the top of my head was when we actually blocked the native aorta, because the native aortic valve had very little in terms of useful outflow, but was incredibly regurgitant, and the they actually just blocked it in the cath lab. The edemas could still supply the coronary arteries, but actually that was massively beneficial for the patient. But that's so unusual. It's been written up as a case study, so that's not a kind of standard practice. But
I think from the paediatric perspective, it really depends what stage of the journey the child's in. So if you've got AV, so you've got TR from the off, that's a very poor prognostic sign, and you're probably not going to embark on a single ventricle journey because you know it's just going to get worse. And then thereafter, if the TR was open, was mild, or the tricuspid valve was actually fully competent in the initial pre-surgery, but then later on it starts to develop when you start saying what's the mechanism. Is it a dysplastic valve, or is it just RV dilatation? Is it something that would get better as you offload the heart through, going through the Glen and then the Fontan, or is the valve going to need something surgically doing at the next operation? So it really depends on the finer details of what's causing the regurgitation, but certainly pre-starting surgery, if there's signs of significant TR, that's usually a poor prognosis sign. They're going to be a non-starter.
Super. So last question, just as we are running out of time. We've had loads of good questions, so thank you very much, and sorry we've not been able to answer them all. So just as a take-home message, even though now everyone will be competent in scanning a hypoplastic left heart patient, if one of these patients would attend a non-congenital centre, what are the sort of red flags you'd be looking out for clinically and imaging wise, and what sort of advice would you give to people who might be scanning these patients in a non-congenital centre?
I can kick that off from an echo point of view if you would like. So what I would say is find out where your regional centre is from congenital, because I think it's really important. If a patient comes to your hospital, they're most likely going to be sick, so on somewhere like ICU, and they might ask for a scan. So my first point of call of sonographer is to contact their centre, the congenital centre, to ask for a copy of the previous report, because that will include all the numbers for like the TAPSI, the RVS primes, etc. And then that's something that you can use to compare, because as we said in the talks, it's not actually the number you get, it's whether it's a change from previous. So that would be really helpful from your point of view. And also it's just to get advice from your congenital centre, because it's quite daunting if you've never scanned these patients, and it's just taking the advice from sonographers of what it is you need to look for and what those numbers were on the previous scan. So it's worth reaching out and finding out your centres. So that's what I'd say from an echo point of view. And most importantly, don't panic. It's not as hard as you think. And as I say, just get that previous report and that will help you.
Super. Well, thank you everyone for presenting. Thank you to all the presenters, Helen, Sarah, Peter and Jan. Thank you very much for attending. And I hope everyone has learned a little bit about the single ventricle and hypoplastic left heart, and how to image, and how these patients are managed all the way from antenatal up until adulthood.